Assalamu alaikum. My name is Razan AlQahtani. I'm a fourth year KSU medical student, and today I will talk about non-alcoholic fatty liver diseases. So first of all, I will talk about the definition and epidemiology of the disease. It's non-alcoholic fatty liver disease. So it's a liver disease where there is accumulation of excess fat in the liver cells in people who drink little or no alcohol. It's common medical condition increasing with obesity and metabolic syndrome. It's the leading cause of liver cirrhosis and liver transplantation in many countries. About epidemiology, there are 1 billion individuals worldwide, and its most common cause of abnormal liver test and most common cause of chronic liver diseases. And the second leading etiology of liver disease among adults awaiting liver transplantation, and this indicates high rate mortality. We'll move to pathogenesis, and we will talk about the development of the disease, and it's based on the development of obesity and insulin resistance, as we said, and metabolic disorders, and this lead to increased hepatic free fatty acid accumulation. How this happen? Insulin resistance is the first step, and this will lead to lipolysis and lipogenesis. Lipolysis will end up with free fatty acids, and after that the liver will uptake these fatty acids, and it will accumulate as a hepatic triglyceride. And in lipogenesis, because of excess fructose, again this will lead to accumulation of hepatic triglycerides. So this imbalance between the rate of synthesis and rate of catabolism of fatty acids in the liver leads to the development of steatosis, which is fat accumulation. But the phases of fat accumulation and inflammation are overlapping. It means there is a time between the fat accumulation and the phase of inflammation. It's two phases. In fat accumulation, due to high fructose intake, plus insulin resistance or any other factors, as we said, we will have a hepatic triglyceride accumulation in the end, and then there will be a lipotoxic effect. This will release many cytokines and inflammatory markers, and here we will get an inflammation. And there's another phase after inflammation, which is a fibrosis, and this is the worst prognosis with non-alcoholic steatohepatitis, and we will talk about this in the next slides. We will talk about the classification. There are two types of this disease: non-alcoholic fatty liver disease and non-alcoholic steatohepatitis disease. Non-alcoholic fatty liver, there is a steatosis, which is a fat accumulation and no inflammation. So this means it's simple, benign, and there is no progression. In the second type, there will be an inflammation with steatosis. So there is a fat and inflammation, and they are progressive, and this will lead to cirrhosis and hepatocellular carcinoma. And here we will see a simple steatosis. This is only fat in the liver, and in the second picture there is non-alcoholic steatohepatitis. There is an inflammation, and in the third picture there is an fibrosis, which is the bad or the worst prognosis, and it means there is an cirrhosis. And here we will talk about the criteria of the disease. We have 2 points. The first point is liver fat percentage, and the second point any other secondary causes. For the first point, we must have liver fat more than 5%, and this will estimated by cross-section on histology and by invasively by MRI. Second point, we have to exclude any other secondary causes for hepatic fat accumulation, such as alcohol consumption, more than 30 gram for men and more than 20 gram for women, and long-term use of steatogenic medication and monogenic hereditary disorders. Move to risk factors. Non-alcoholic fatty liver disease is considered by many to be the hepatic manifestation of the metabolic syndrome, so they are strongly associated with each other. The first thing is insulin resistance, obesity, which is central, type 2 diabetes mellitus, hyperlipidemia, and these four things is the most common things. And even the male gender medication as tamoxifen, which is estrogen antagonist, treat infertility and breast cancer. And sedentary lifestyle, and the Western diet, which is a standard American diet, it's a modern day style diet that contain high amount of processed foods and red meat, high fat dairy products, high sugar foods, and prepackaged foods, and hypertension as well. For history and symptoms, it's mostly asymptomatic, but here we will talk about only a non-alcoholic fatty liver, because non-alcoholic steatohepatitis patient usually will present late with a complication with cirrhosis, portal hypertension, varicose hemorrhage, and hepatocellular carcinoma signs. So here we will talk about only a non-alcoholic fatty liver patients. Usually there is no symptoms, and if there is symptoms, it will related to other condition like diabetes, obesity, or symptoms of liver decompensation like fatigue, bruising, bleeding, itching, jaundice, ascites, fluid buildup in the ankle and legs, abdominal pain or nausea. But the more important thing to exclude other causes of fat accumulation like alcohol consumption, any type of viral hepatitis, autoimmune diseases, Wilson, stigmata of liver disease. And second, you have to identify the risk factors like obesity, diabetes, dyslipidemia, metabolic syndrome, hypertension, and Asian and Hispanics patient. For the physical examination, if he develop any symptoms or a general figure of a fatty liver patient, there will be abdominal obesity, enlarged liver, and signs of cirrhosis and liver decompensation, as we said in the previous slide. Jaundice, fatigue, weight loss, easy bleeding and bruising, bloated abdomen, which is ascites, swollen legs, and confusion, slurred speech, or drowsiness, which indicate a hepatic encephalopathy, which is another phase of liver diseases, nausea or loss of appetite. For investigation, imaging, we have ultrasound, CT, MRI, and elastography. For ultrasound, it's best initial, but it has a low sensitivity, especially if the liver fat is less than 20%. But we will see in the ultrasound enlarged liver and increased echogenicity, which is a bright thing, as we see here in the picture. For CT, it will be hypodense picture, and MRI and MR spectroscopy and elastography. Elastography is non-invasive and it's painless technique. and it's determine the stiffness of the organs or any other structure by direct low frequency vibration into the liver, and it's commonly used for liver. For laboratory, the first or best initial thing is liver function test, and mostly it will become normal or elevated bilirubin, AST/ALT, AP, and GGT. And we have to do a hepatic panel, albumin, INR, and platelets, and emerging non-invasive panel. But the best initial is liver function test, ultrasound, and gold standard is liver biopsy. But the liver biopsy is only used for non-alcoholic steatohepatitis, not for fatty liver. So as we see here, the investigation of fibrosis assessment, which is steatohepatitis. The histological definition of non-alcoholic steatohepatitis is based on combination of three lesions: steatosis, which is fats accumulation, and hepatocellular injury and inflammation. And the degree of fibrosis is the most important factor in prognosis. So we assess that by non-invasive methods as liver elasticity, as FibroScan, or serum markers scores, or by liver biopsy, which is the gold standard for diagnosis of non-alcoholic steatohepatitis. This will confirm diagnosis and fibrosis stage, which is most important thing, and exclude other diagnoses when there is a possibility of extents of other liver diseases, but this is not needed routinely. Okay, finally, the management. We have two lines of management: pharmacological therapy and lifestyle modification. The pharmacological therapy is focused on metabolic disorder. We have to improve insulin sensitivity with the glitazones, treat dyslipidemia with statins, and control hypertension, reduce oxidative stress effect, slow or stop necroinflammation, fibrosis, and improve underlying metabolic syndrome. So we have to control the metabolic disorders. Second thing is lifestyle modification, and it's the most important thing. We call it cornerstone management. It's only intervention that has evidence of its benefit and safety. And here we will arrange it according to the strength of evidence. The first thing is weight loss. If he lose 5% of overall weight, this will improve steatosis. And if it's 7%, this will improve non-alcoholic steatohepatitis. And if it's 10%, this will regress fibrosis. For the dietary modification, low glycemic food will reduce liver fat, and we have to avoid a high fructose containing food as well to reduce the risk of hepatocellular carcinoma. And if there is increased mono or polyunsaturated, this will cause non-alcoholic steatohepatitis and fibrosis with some evidence. The last thing is physical activity, aerobic and resistant activity independently. This will reduce the liver fat and as well as non-alcoholic steatohepatitis and fibrosis. But there is a little evidences of this. We have to stop alcohol for those who drinks and treat other condition like diabetes, hyperlipidemia, as we said, to control metabolic disorders. And we have other interventions like bariatric surgery. This type of surgery for obese individuals with both, it's improved both non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. And it's another way for weight reduction. This will improve the liver disease. And it improves other comorbidities like diabetes. For vitamin E, it's for abnormalities of the coagulation, and it improves non-alcoholic steatohepatitis in some studies, but it's not good for diabetic patients because it's increased the hemorrhage, and this is not good for them. And bioglitazone and liraglutide, it's hypoglycemic medication. And the last thing is obeticholic acid. It's good for other liver disease that destroy bile ducts, but has some evidence of improvement of non-alcoholic fatty liver disease activity score for at least 2 points. But it needs more data, and it has one bad thing, that there is a rebound weight gain. So it's better to stick on lifestyle modification and control metabolic disorders. In summary of management, as we said, the best thing is to reduce body weight and lifestyle modification, then through other methods like pharmacological for metabolic disorders or bariatric surgery for weight reduction. And for diabetic patients, we have to use bioglitazone or liraglutide. And for non-diabetics, we can use vitamin E. And that's it. Thank you for your listening. If you have any question, please contact me on my email. And good luck.